This video footage is provided courtesy of Dr. Frank Vlegar from the University Medical Center, Utrecht, the Netherlands. This is a 68-year-old female with unresectable pancreatic cancer, status post-biliary SEMS placement. She was admitted with acute cholecystitis and ERCP was attempted. The cystic duct could not be cannulated. She's therefore referred for EUS-guided gallbladder drainage. The gallbladder is well visualized on EUS. It measures around 38 millimeters in cross-section. The wall is thickened at about 8 millimeters. The interposed wall measures about 10 millimeters. There are no interposed vessels in the wall. We now proceed to puncture the gallbladder with a 19-gauge FNA needle. Tip is nicely seen in the lumen. We insert a guide wire into the gallbladder, allow it to coil a few times, remove the needle. Diathermy is now used to enlarge the tract. A 6 French cystotome is advanced over the wire into the gallbladder. The cystotome is removed and exchanged for a 4 millimeter balloon. The tract is dilated to 4 millimeters, which is generous enough to now insert the AXIOS sheath, which is 10.5 French, and the distal flange of the AXIOS stent is deployed, well seen on ultrasound, and the proximal flange is released under endoscopic guidance, independent of the distal flange. Bile gushes forth into the duodenum. The proximal and distal flanges hold the walls in apposition. An overview of the proximal flange draining infected bile from the gallbladder. The CT scan shows the AXIOS stent draining the gallbladder, which is now filled with air, shown with the arrows, and the biliary SEMS is also seen. With the increased use of biliary SEMS, especially covered ones, we can expect to see more cases of acute cholecystitis complicating biliary drainage.